with Files. This is our series LIMBWatch, the show where innovation meets prevention and where we keep a close eye on the latest breakthroughs in limb preservation, diabetic foot care, wound healing, and vascular health. I'm your host, Dr. G, and today we have the most amazing Dr. Gary Rothenberg is a board-certified podiatrist, a certified diabetic care and education specialist, a certified wound specialist, who currently holds a dual appointment as a clinical associate professor of internal medicine and vascular surgery at the University of Michigan School of Medicine in Ann Arbor, Michigan. He is also the director of fellowship training for the 2-year research-based fellowship at that institution. Additionally, he serves as the director of medical affairs for Podometrics, a mission-driven company committed to preventing avoidable amputations among people living with diabetes. He's also a graduate of Ohio College of Podiatric Medicine, and he completed 3 years of residency training at the University of Texas Health Science Center in San Antonio. Private practice, VA, and academic practice and industry roles have all focused on conservative and surgical management of diabetic foot. Education has always been his passion, whether working with students, residents, colleagues, and most importantly, patients. Dr. Rothenberg believes education is the key to success, prevention of diabetic related lower extremity complications. Welcome, Dr. Rothenberg. I'm so sorry, I'm getting a little tongue tied.
All good. Thank you so much for having me today. Excited for the conversation ahead.
Okay, yay. Okay, so Dr. Rothenberg, you spent much of your career in limb salvage and amputation prevention. What originally pulled you into this field so deeply?
Yeah, it's a great question. So, yes, I've been practicing about 26 years now. And it all started actually my first semester, my first year of podiatry school. I went to the Ohio College of Podiatric Medicine, as you mentioned. And my first year, Dr. Larry Harkless came up. It was one of those after class events, the ones where they try and attract you with pizza. And then there's some guest lecturer, right?
Yeah.
A student, poor starving medical students, right? We wanted the pizza, but you got to hear a lecture. And Dr. Harkless came and gave a talk at the Ohio College, which is now Kent. And there was something very inspiring about the presentation that he gave on diabetes related complications and the work that they were doing in San Antonio. And then he he showed some slides about the residency program that he was the residency director for at the Health Science Center. And so from the back of my mind, first semester of first year of podiatry school, I had it in my head that was a population of patients that I could really see myself working with, as well as Dr. Harkless could be somebody that I would really enjoy working under, training under. And so my proverbial dream came true because obviously fast forward, I did end up doing a residency there. And today, Dr. Harkless continues to be a wonderful inspiration and mentor to me. And so that was really my initial kind of interest in the diabetic foot and making a difference in that patient population. I attribute it to Dr. Harkless.
Wow, that's amazing. That's actually quite impressive because you just knew from first semester. That's impressive. Wow.
Yeah, it was impressive, but also, again, I say it was a dream that came true. I had my mind and my heart and set on it, and so I try and inspire students and trainees to kind of have that vision early on as well.
Oh. At what point did you realize that diabetic foot complications were not just a clinical issue, but a system level crisis?
Yeah, great question. So, right out of residency, I thought it was really important. I always knew I wanted an academic career and I wanted to teach, but I also, coming out of residency, thought it was very important that I had experience to believe what I was taught. So, I thought I wanted to go into private practice, which I did right out of residency. I practiced in the greater metro Atlanta area. And right from the beginning, I thought, okay, I'm going to Atlanta. I'm going to practice in the suburbs. I'm going to see a general patient population. And then I realized right away that there were people that I was treating who had horrible Charcot foot,
Mhm.
who were battling diabetic foot ulcers. And the thing was, they're most of the time they're hidden, right? That they're
Mhm.
inside a shoe. But I realized these were also people who were in my community, my neighbors, the people that were shopping at the same grocery store alongside of me. So I realized very early in my career that you don't look a certain way necessarily to have a
Mhm.
diabetes related foot problem. And then I did pursue an academic career, and my next move was to the VA, where I spent some time in the Veterans Hospital in Miami, Florida. And of course, there that experience just expanded because so many veterans are very comorbid, as I'm sure your listening audience can appreciate and understand. And they have such complications beyond their diabetes. And now, as an academic practice at the University of Michigan, and also my work in industry, it just goes on. And I'm realizing, to your point, the systemic issues many times are not clinical, but they're also more around those non clinical factors or social determinants of health, which I've really come to appreciate in my career, plays such a significant role in outcomes.
Oh, wow. And just a side note, I literally just said in my last episode, I was like, I noticed a pattern. I said, it seems like some of the best people in wound care are coming from the VA. And now you just said like the VA. I was like, they're like putting out some great wound care specialists.
Well, the VA is amazing training, and I actually really miss practicing in the VA. The veterans were always so very appreciative of the care that they received, and I think it's a vulnerable population. Oftentimes, yes, the typical veteran that we're managing with a diabetic foot complication may be like a 65-year-old male, but oftentimes they have very supportive caregivers, which I hope we have a chance to talk about because the role of caregivers is really underappreciated, I think, in the wound care space. And so when somebody's spouse or child comes with them along with that visit, I often see that outcomes are improved. But the VA, the veteran population, I think it's a wonderful training ground. Also, access to lots of different opportunities for advanced wound care modalities. And I think the mantra of, hey, if you can manage that patient population, do it well, then you're going to be pretty successful in the wound care space no matter where you practice.
Oh, wow. Okay, so you mentioned in past episodes, I've followed you whenever you've done podcasts with other people in past conversations that diabetes has touched your own family life. How has the personal proximity shaped your approach to patient care, urgency, and then preservation?
Yeah, interesting. So I was about 10 years into my practice experience when my son, actually, who's now 21, was diagnosed with type 1 diabetes. He was in DKA, and it was a really frightening experience. And briefly, I'll share, he was playing basketball. He was 8 years old playing basketball. We lived in Florida at the time. It was a really hot day, and he wasn't feeling well overnight, was vomiting, all the good stuff, that goes along. I thought he was dehydrated, took him to the emergency department, and the nurse practitioner who diagnosed him in the ER basically looked at me and said, I think it's a little bit more than dehydration. His blood sugar is not reading on the meter. And so it was really interesting that my initial response was, okay, how do we get rid of this? Like
Mhm.
knowing that but I was wearing my dad hat at the time, right?
Mhm.
Not my doctor hat, but it was really an interesting experience. So I would say, of course, having that personal kind of interest and influence and investment into diabetes, it's like, diabetes is no longer feet. Podiatry is no longer feet. It's like diabetes has a face, and that's my son's face. And I want my son and everyone living with diabetes to be healthy, productive members of society and to live a long, healthy life, avoiding these complications, which so many of them are. So, in living with somebody with diabetes, of course, as I mentioned, my son is now 21 and he's successful in college, and he actually plays football and college, and he's doing really well. But, the idea is when you're personally invested in it, it becomes more than kind of a job. It's really a passion. And I think I've learned more when you live with somebody that you love who has diabetes, you learn more than any textbook could tell you for sure.
Wow, definitely. Wow, that's never thought about it like that. So, do you think amputations is sometimes still treated as a default endpoint rather than a last resort? And why do you think that mindset persists?
Yeah, great question. So unfortunately, I think again, the listeners are going to realize and know primary amputation does occur all too often, and I look to the literature, I listen to podcasts too, and attend lectures, and probably one of the people that's following this so closely is Dr. Felucio Faccariti. I'm sure many of your listeners are familiar with the work that he's doing in the Mississippi Delta. And it seems like he's trying to change that, of course, but it still seems like, unfortunately, Black and Brown communities, especially in the South or in more rural areas, we know that those folks are experiencing primary amputation without attempts at limb salvage, meaning we have to do more. We have to try harder. This sounds counterintuitive, but we have to admit more patients to the hospital for debridements, for IV antibiotics, and not for primary amputation. So I find it hard to make big, broad brushstrokes, but theoretically, people in the wound care space who have the mindset that doing a primary amputation will eliminate the wound and solve the problem. We have to get rid of that mentality because, as you and I know, you're just creating new problems. You're not solving all the problems. These folks are going to experience wounds to their BK stumps. They're going to never be ambulatory again. They're going to have significant quality of life impairment. They're going to have mental health challenges. And so we're not solving a problem by doing a primary amputation. We're actually creating new ones.
So, Dr. Rothenberg, what do you think is the most misunderstood early warning sign that clinicians or patients tend to underestimate when they have diabetes?
Yeah, I think about this a lot, and I think about it from a research perspective too. Like, what do we know and what are still the unknowns? I think if I had all the money in medicine to spend in diabetic foot limb preservation research, I would find a cure for neuropathy. I think
Ah.
neuropathy is the root of all evil. These patients, again, you and I and the listeners who are treating these patients, it's amazing the things that will happen because they do not feel anything. So, if we could prevent neuropathy from progressing to numbness, I feel like that would be a significant influence. And then I guess I'd spend a lot of money on neuropathy. The other big the big chunk of money that I would also spend is in prediabetes, right? We know that we have an obesity problem in the United States. We know if we could prevent people from tipping from prediabetes to full blown diabetes, we may have the opportunity. Obviously, if you don't have as much diabetes, you don't have as much complications, but worried about where we're headed with the amount of prediabetes that we have, especially here in the United States. There might be a little bit of promise with the new GLP-1s, right? Everybody is
Uh-huh.
talking about those and how we are managing obesity a little bit better through those medications. But we need to make sure that the people who need them can afford them and have access to them. And so I think those are two big areas that if we could get a better handle on those challenges, one is neuropathy and two is prediabetes, we'd have a chance at reducing amputations and wounds in the country.
Well, that's great. Just to piggyback off of that, you saying that where do you think that diabetic foot care is currently the weakest? In detection, monitoring, or patient adherence?
Yeah, so all of those need work, right? The one that I think gets thrown around too much, and being transparent, is that adherence. I've learned very early in my career that oftentimes patient non-adherence is actually not a patient problem, it's a provider problem. And I've challenged all of us to think about Are we clear with our expectations with patients? Have we, in fact, given them choices? Have we challenged them to understand what are their own limitations? Have we asked them to compromise? And many times I just believe that patient noncompliance gets thrown around, and I don't like hearing that when I listen to folks on podiums, because again, I would challenge providers to say, are we doing our job in education? And I mentioned caregivers before. They can have a very significant influence on compliance and adherence and doing the things, because everything that we tell patients to do, we know is the fastest way to heal a wound, prevent infection, prevent hospitalization. But do the patients really know why we're asking them to do that? Have we engaged them in the process? And I think there's promise with some of the newer technologies and telemedicine to actively engage patients in their own care. So I probably, am a little bit biased, but I think that non-compliance or non-adherence is an area that we as providers could work a little bit more on. Yeah, I think we need to do a better job in prevention, because I feel like we're pretty good at healing wounds. We're not so good at keeping them healed. That's the
Mm-hmm.
challenge. And I share that with my patients on graduation day, as I call it, right?
Mm-hmm.
I'm always thrilled, and we could take a lesson from the cancer world. We should have patients ringing a bell or doing something, you
Yes.
know, documenting that they've done such a great job. But as I share with my patients, that day is when the challenge begins, because keeping that wound healed is what we're ultimately trying to do.
That's beautiful. I like that idea too. So, do you
David
think?
Armstrong is so, he's so passionate about using that oncology analogy, which I found
Mm-hmm.
very useful in my career, educating patients. Unfortunately, all of our families, we know somebody who's been touched by cancer, whether it's a family
Mm-hmm.
member or a friend, and they understand, when you're diagnosed with cancer, how do you get rid of it? The same thing when you're diagnosed with diabetes or diabetic, just like I had that visceral reaction with my son, how do I get rid of it? Or when you're diagnosed with osteomyelitis, how do we get rid of it? So I think that resonates really well. So yeah, ringing a bell or doing something upon healing your wound, but then understanding, as Dr. Armstrong so eloquently says, now you're in remission, right? You're not cured,
Uh-huh.
you're not healed. We have to make sure, and we have to do surveillance, and you have to be seen, and all those good things.
Yeah.
So
So, Dr. Rothenberg, for those who are unfamiliar, can you explain how the Podometrics system works and what it actually is measuring in diabetic foot risk monitoring and surveillance?
yeah, so I was introduced to Podometrics about 15 years ago when I was at the VA in Miami, and they were looking for clinical sites to do the feasibility and efficacy study of the SmartMat. So, and I participated in that clinical trial as a co-investigator. And what we at Podometrics are very adamant about is we didn't invent the concept of temperature monitoring for high-risk patients for recurrence of plantar diabetic foot ulcers. We didn't invent that concept. Again, Larry Lavery, Dave Armstrong, and this technology, it actually goes back 50 years or so to the works of Paul Brand, when Dr. Brand, who many of, again, your listeners will probably be familiar with from total contact casting and all of that pioneering work. But Dr. Brand did some trials in the 1970s that showed inflammation precedes ulceration and complications like Charcot foot. So in his famous words, the foot will heat up before it breaks down. And then Lavery and Armstrong did all this great work with the handheld thermometers, where they gave them to high risk patients and said, monitor your feet for 2 consecutive days of temperature asymmetry, and then you're in a hot spot, and call your doctor. If you do your temperature readings to your right hallux and it's 2 degrees warmer than your left hallux. So that was really, really useful. And they showed through 3 randomized clinical trials that you could reduce diabetic foot ulcer recurrence by 72% if you just add temperature monitoring onto a good prevention strategy. So that means shoes and inserts. That means daily foot checks by the patients. That means routine foot care and appropriate intervals and foot education. But so that science was really sound, but it was a burden to the patients. Again, your listeners think about the average patient that they treat. It's a complicated process to do temperature monitoring to yourself. So Podometrics in kind of really didn't invent the concept, but they did innovate it. So it's a bath mat essentially that has 1,000 temperature sensors, and you stand on it, and it takes 20 seconds a day to do a thermogram or a heat map of the plantar surface of the feet. And then through remote temperature monitoring, there's a team of providers around the country, a clinical team who are monitoring those patients for temperature asymmetry. And the burden gets shifted away from the patient. And now if there is a temperature hotspot, a nurse or a team member from Podometrics actually calls Mr. Jones and says, "Hey, Mr. Jones, you know that mat you're stepping on every morning? I'm seeing some inflammation in your right heel," for example. And
Mhm.
essentially, they do a telephonic history and physical and recommend offloading, because the data shows inflammation will precede a clinical presentation of a diabetic foot ulcer by about 5 weeks. So it starts to heat up before it breaks down. And if you can get the person to reduce their step count, stay off their feet, take care of any pre-ulcerative areas, wear appropriate shoes and inserts, then you don't have to have that causal pathway that's so familiar to all of us that will lead to ulceration, infection, and ultimately amputation. So it's temperature monitoring, but it's done remotely, takes away the burden from the patient, and really has shown to be clinically effective and easy to use, so patients will use it.
Okay, so how does the simplicity, because the most interesting aspect is that it doesn't require a complex setup or continuous connectivity. So how does that simplicity improve the patient's compliance or their real world use?
Exactly. So I think you're alluding to it. So when the Podometrics SmartMat is prescribed for a patient, we have an onboarding specialist, somebody from our team who will call Mr. Jones and welcome them into the program, educate them on the benefits of it. But the most significant thing that they do is because it's 20 seconds per day, they ask them to associate it with something else that they do on a daily basis. So literally you can put that mat in front of your sink in the bathroom, and as you're brushing your teeth in the morning, do your foot scan. 20 seconds is all that it takes, so it's not a huge burden. And again, maybe it's sitting down taking your morning meds at the breakfast table, take your blood pressure if your provider wants you to take your blood pressure, do your foot scan, and you move on. There's no Wi-Fi, there's no hub or portal. It actually is cellularly connected. So if the patient has cell phone service in their home, then the SmartMat will work as well. It connects with the local cell tower closest to the patient's home. And generally we don't have trouble even in rural areas or in New York City where there's tons of people. So it's very versatile, easy to use, and that's the design, which again, as you're alluding to, really influences that patients will do it because it's so easy. Also, keep in mind this is a high risk patient population, is generally utilized for secondary prevention. So I believe that when patients have the lived experience of losing 6 months trying to heal a wound or looking down in the shower every morning and seeing toes missing, if they can actively engage in a process that will help prevent that from occurring again, there's higher adherence as well. We want to be in the primary prevention space because that's ultimately, I think, best help people prevent their first foot ulcer. But right now, it's generally reserved for secondary prevention. And I believe that that plays a big role in our adherence because when the Podometrics team calls Mr. Jones, he's going to pick up. They know that Mr. Jones knows that potentially we have information to share that's going to prevent another toe amputation from occurring.
So how do you see remote monitoring changing the timeline of ulcer detection, shifting it from late presentation to early intervention?
That's definitely the goal. And already we have wonderful clinical experience through the VA where remote temperature monitoring has been a strong initiative. And at Podometrics, we've monitored probably over 20, close to 25,000 veterans over the
Wow.
past 8 years. So we have lots of data. And through actually some other health plan partners that we've worked with, as well as the VA, we are seeing that shift towards less emergency department visits, less hospitalizations, definitely less DFU recurrence, less amputations. And I always say when you're clinically effective, you'll be cost effective. So you and I, as providers, we know that it's the right thing to do for quality of life to prevent these things. But health plans appreciate that prevention is actually more financially advantageous than paying for these very expensive, hospitalizations and amputations.
Oh, wow. So, Dr. Rothenberg, what do you believe are some of the limitations of remote diabetic foot monitoring systems that people don't discuss enough as yet?
Yeah. So probably a couple come to mind. One is reimbursement. So we're at Podometrics very fortunate that we work with many health plans that are at risk for their patients. They recognize that, again, it's more cost effective to prevent these wounds than to pay for them. But I think we need to do more work in the reimbursement world and making sure that our providers are incentivized. There are lessons to be learned from continuous glucose monitoring from the CGM world because,
Mm,
again, you actively engage with your CGM. Again, my son wears a Dexcom, right? The Libre
mhm,
is out there. All of these are very helpful because they engage the patient, but the provider is also equally benefits because he or she can make changes in the clinical course from that data. So I think once we get patients and providers to engage with the data and it's a reimbursable kind of expectation, then we'll see more adoption. The other area is making sure that those patients who are most vulnerable, for example, in our world, in the DFU world, and specifically we're talking about Black and Brown communities and patients living in rural areas, we need to ensure that they have access to the technology so that we can utilize it and connect them with the providers. Usually they're less connected as a rule. So I think making sure that the right people have access to the technology and that we get reimbursement. Those are the areas that are need a little bit more work still.
okay. So, what do you think that the next 10 years of limb preservation look like to you? AI, wearable tech, or structural healthcare reform?
Yeah. So I'm hoping it's a little bit of all of that for sure. And I'm imagining, we're practicing at the top of our ability right now, whether that's with access and products to access that are excellent at healing. I think we're moving in the wound care field. Hopefully we're moving towards better diagnostics and more point of care diagnostics. So I always kind of joked 20 years ago that we would biopsy a wound and put it through some machine and it would spit out what it needs. And I believe we're getting closer to that. You
Yeah.
can do more rapid point of care infection diagnostics and things like that, or healing potential diagnostics. So I'm potentially excited about that. AI is a little bit more fuzzy. And I think as providers, many of us are still a little bit like, well, how are we going to use AI? I don't think it's going to replace us. I don't see a world
Yeah.
where some machine is debriding wounds or some,
Yeah.
robot is having a conversation around amputation versus medical management. I just don't see that happening. But I hope that AI does some really good work in helping us risk stratify patients better, predictive analytics of who may be on the trajectory towards healing and who may be struggling. I hope that AI can help us as providers do the mundane things that we don't want to do, like charting. And, none of us went to med school to sit in front of a computer and generate a note. So I'm optimistic around that. The part that's the challenge that I'm less kind of savvy in is what you mentioned in terms of, reform and policy and reimbursement. Thank goodness there's really smart people doing that, but as we all know, that doesn't happen fast enough.
Mhm. Yeah. So, do you think we'll ever reach to a point where diabetic foot amputations are considered a never event?
I would love to be there. I really would.
Say I love to
I
be there.
Yeah, I mean, unfortunately, there are still indications, right? And we
Yeah.
still know sometimes it is the unfortunate decision that has to be made. But I guess I would answer your question and going back to the oncology world, I would love to see academic centers. I would love to see centers of excellence that are pop up around the country and around the globe. And taking from that oncology world, I would love to see the concept of tumor board extrapolated into the wound care world. So, in
Mm.
other words, nobody should be allowed to have a proximal amputation without a
Mm.
multi-specialty group reviewing that decision and of course having the patient involved in that decision making process. But I would love there to be kind of this consensus, and nobody should undergo amputation without really aggressive attempts at limb salvage. And if it is the ultimate decision based on biology, based on, what's needed to save the limb and life, of course, oftentimes, unfortunately, we have to do that. But that concept of an amputation board, I think, is something aspirational. Probably
Wow.
only happen in academic centers, but I think, if my mom or dad had a diabetic foot ulcer and somebody said amputation, I would love a multidisciplinary group to get together and make sure that that is the right decision and that there's no stone unturned. When I train students and residents, I say you have to treat every patient in the hospital bed or in the clinic chair like they're your favorite patient person in the world, because they are somebody's favorite person, right? They're
Hmm.
somebody's spouse or child or parent, and you would want that done for your parent or favorite person in the world for sure.
Yeah. So, if you could redesign diabetic foot care from scratch, what would you immediately eliminate from the current system?
Wow, that's a good one. Probably I would eliminate the bureaucracy of us not practicing in the same systems or having access to, like, I need to know what the endocrinologist is thinking. I need to
Yeah.
know what my vascular, colleagues are thinking. I find, and the biggest challenges that I've had in my career is when providers are not on the same page.
Hmm.
And then the infectious disease doc goes in and says, "Well, we could try antibiotics." And the surgeon goes in and says, "Nope, there's no option for revascularization. You need an amputation." And then the podiatrist, I'm making broad generalizations, but the
Hmm.
podiatrist wants to try limb salvage and do skin substitutes, right? Or other things. So I feel like I would eliminate the discord, the inability to get on the same page with everybody. And those are system issues like you asked about before. But I think when we present a unified front to the patient, they're less confused. They know what's going on, and we're all kind of headed towards a better outcome.
And I really like your concept of the amputation board because it also brings accountability to the healthcare system.
For sure. For sure.
Yeah, so I really, really like that. So, considering all the patients you've helped and if those are lost in due to delayed care, what is one of the messages you wish every clinician and patient understood about diabetic feet?
Yeah. So again, going back to what I said earlier, neuropathy is the root of the evil. So these folks, patients, we really need to underscore you don't have that gift of pain. That's another, one of Paul Brand's famous lines. If you walk into a clinic and you see these wounds and they should hurt. So we have to emphasize to our primary care colleagues, to other folks in this space, frontline providers, emergency department providers, that neuropathy is masking a lot in this patient population. And so the patients themselves need to do their good work on a daily basis, making sure that they're looking at their feet, touching their feet, using caregivers, other people in the home to help them, because early detection is the best way to avoid those complications. And as you're mentioning, delay in treatment, unfortunately, there's many times we can't do things on the back end that if we had the opportunity sooner, it would be a much easier, simpler, less costly in terms of finance, but in also terms of outcome, event. So that early, I get it. One thing that I've seen in my career that delayed presentation can also be a psychological event
Hmm.
because many of our patients, obviously diabetes running so strongly in families, they've seen their parent or their aunts or their uncles or their grandparents, experience these complications. And then it's kind of like they don't want to go seek help because they know that somebody's going to tell them that it's their turn to have an amputation. So that psychological barrier is pretty significant as well.
Okay, so we got through all the really great questions, and now we're to our rapid fire questions. So we're gonna close in. So, Dr. Rothenberg, what do you believe is the most overrated treatment in wound care?
Probably skin substitutes. I think that's coming to light now, but yeah, I think we need to be have better data around them. And I'm actually kind of thankful that CMS and other folks are looking at them critically. Thankful we have them, but I also believe so strongly in prevention that if we prevented wounds, we wouldn't need all those advanced modalities.
Mm, I agree. So, Dr. Rothenberg, what do you believe is the most underrated treatment in wound care?
I mean, probably diabetes management. And I've seen the significant effects of continuous glucose monitoring. It's empowering to patients, it's interactive with patients. So I'd love to see something like that in diabetic foot care. But overall, I think for our diabetes patients, I would have every patient on a CGM to make sure that they know, hey, look, the reality is they're going to eat pizza or they're going to have, some birthday cake, but you need to know what's going to happen to your blood sugars. And that information is really, really powerful.
Okay. And so if you can you tell us the craziest story of wound progression you ever witnessed?
Yeah. So my story goes back to my days as a resident, and I was on call and I met this probably about a 35-year-old male, unfortunately type 1, was blind from his diabetes. He was on dialysis, like all the end stage complications that you can imagine. And he came in because that morning when he was walking to the bathroom, he had, I guess, tile floor, and he felt his toe sticky or the foot sticky, and he realized that he was bleeding. And when he went to bend down and see what was going on, his big toe was missing. And yeah, apparently had a wound on his toe, and he had a Jack Russell Terrier, and
Oh,
the dog bit the toe off, I guess. And the crazy part of the story was that his family brought the toe in on a bag of ice, like you're told to do if that happens in the trauma world. Like, could we replant his toe back on? So that's the crazy story. Of course, we didn't. We ended up having to do a formal, first ray amputation. But that's also the story that I tell when people don't believe me when I say that neuropathy can be so significant. And maybe that's, again, why I'm so passionate about neuropathy and why I've mentioned it several times in this podcast, is because from very early on, I realized the impact that neuropathy has. This guy's toe was bit off by his own dog, and he had no clue. So
wow.
that's crazy. I think that's crazy.
Yeah. I I agree. Wow, that's a story for the books. What's your first go-to move when you see a wound suddenly deteriorate?
Yeah, so I think I go back to my residents and fellows and trainees start to roll their eyes, but I have a talk that I give them that's the 8 key questions of why wounds don't heal. So, as you may imagine, I'm not going to go through all of them, but it's infection, it's bacteria, it's pressure, it's all those good things. So, my move is go back to my 8 key questions and what am I missing, right? Am I getting too tunnel visioned on the wound itself? Do I need to repeat x rays? Do I need to biopsy? Does the patient, have an acute vascular change status? So I believe the mind responds to order. That's the way I was trained. So you examine the patient the same way every single time, and you look at those 8 key questions of why wounds don't heal.
Oh, wow, that's great. They're very lucky. Lucky them. So
Good.
what
Yeah, they probably don't think so in the moment.
what do you think is the hardest anatomical area to heal and why?
Oh, I hate it. My stomach rolls and turns over when I see Charcot of the ankle. Like I just my heart drops into my mouth. I have not had lots of success. Midfoot Charcot, of course, much more common, and we tend to do okay with that. But ankle Charcot is like the worst for me. I just don't have good success when that foot literally is dangling on the leg. Unfortunately, many of those patients need reconstructive surgery, and there's just such high morbidity and mortality with that. I would say Charcot patients are the biggest challenge, certainly in healing them, and even for the midfoot Charcot, the rocker bottom, those are challenging anatomy to heal for sure.
Oh, wow. This is our last question. What do you believe separates a good wound care clinician from a great one?
Yeah. So I love the question. I think it's really sitting down with your patient, bonding with them, not over the clinical factors, but over the emotional factors that are weighing very heavy on this patient population. So, quick story of a patient. We were trying to heal a wound and I was getting frustrated. He was getting frustrated. All the things that I was saying to do, we were trying some advanced wound care modalities. It just wasn't working. And so finally I said, what's going to make this work? I'll just call him Mr. Jones. Mr. Jones, what's going to make this work? And he finally looked at me and he said, I just want this wound to heal so that I can walk my daughter down the aisle next April.
Oh,
Like,
wow.
at that point, I became more motivated, he became more motivated, like, shared burden, like, this is a challenging problem, but now I was invested in it, and I needed to see that picture of him walking his daughter down the aisle instead of not being able to do that or being in a wheelchair. So I think that when you can bond beyond the clinical and let your patients know you're invested with them in this process from an emotional standpoint, they want to do better, you want to do better, and you'll do everything in your power to heal those wounds and keep them healed.
Wow, that's amazing, Dr. Rothenberg. So today we had a great day with Dr. Rothenberg. This has been Limb Watch, where we stay one step ahead of amputation. I'm your host, Dr. G, and a huge thank you to our incredible guest, Dr. Gary Rothenberg, for sharing his knowledge, passion, frontline experience in diabetic limb salvage and wound care. And your work continues to impact patients, clinicians, and the future of the field in a very powerful way. And as in the words of the amazing chef Martha Pierre White, a person who works with their hands is a laborer, a person who works with their hands and their brain is a craftsman, and a person who works with their hands, brain, and their heart is an artist. And thank you, Dr. Rothenberg.
Thank you. You're doing wonderful work as well, so thank you so much.